Well, first of all, want to thank everyone for joining us. Always enjoy the opportunity to get together with Kelvin and talk about um, some of the various aspects of specifically prosthetics. Is what it's been here recently. We've talked about suspension systems. We've talked about prosthetic feet. Today at the for this POI Connect conversation, POI Community Connect conversation, what we're going to talk about specifically are K levels and why K levels are important, why patients need to understand K levels, and how understanding them can help them realize what level they need to achieve to get into a different type of prosthesis. So my name is Russ Sorrells with the Prosthetic and Orthotic Institute, and this is Kelvin Jones with the Prosthetic and Orthotic Institute. He is the lead clinician, and we're just going to have kind of a question and answer session today, again, specifically on K levels and how they affect our patients as well as our referral sources, so, and how they're determined specifically as well. So go ahead, Kelvin, what did I miss there?
So to follow up on our last conversation we had when we were mentioning suspension systems, and then we talked about prosthetic feet, to tag and piggyback on along with prosthetic feet, today we're going to talk about K levels and how does that correlate and relate to other prosthetic conversations we've had. So Russ, you can go ahead and start our PowerPoint presentation today. And as we're beginning, I'll go ahead and show you guys, we're going to break this down and talk about our documentation and K levels in levels of 0 to 4. So our next slide here is going to show us back around 1994, 95, Medicare designed a system that would help us as clinicians and help you as patients to understand the criteria you had to meet certain spectrums to get a prosthetic foot, a certain type of prosthetic foot. So I want you to think about it like this. Sometimes I summarize it to our patients in this way. You're 16, right? My daughter just turned 16. She wants a car, right? And so we said, tell you what, we're going to start with a very basic car, and we're going to find out what your levels are, what your activities are, what your needs are with the car. At this point, it's very minimal. And so we're going to give you the very basic car, number one, so we can trust you. Number two, so we can find that you're responsible with what we're going to give to you. And number three, we're not going to invest a terrible amount of money and resources into this because we just want to get you out and moving in the community and learn for you to see what it feels like to be in the community driving, right? And so how does that relate to prosthetics and K levels? Medicare says, look, not everyone needs a Corvette. Not everyone needs a Porsche. Not everyone needs an SUV. Certain folks have certain needs in their lives. And that has a lot to do with what you did before your amputation, what your activities were, what's the result of your amputation, and what level do you want to get back to. Some folks in this area, especially geographically where we live in this part of the country, a lot of farmland, a lot of industrial occupations, a lot of uneven terrain. If you live up near Asheville, if you live in the mountainous area, hilly area, it requires different terrains, different outcomes for prosthetic feet. So with that said, we now have feet to meet those criteria.
Well, let me step back for just a second, Kelvin. Sorry to interrupt you, but I want you to clarify, what is a K level and why do our patients and referral sources need to understand about these K levels?
So mainly, it's again to have Medicare is our biggest payer sources. So us as clinicians, as we look across the medical field, especially with the baby boomers getting to the age of retirement, more and more of our folks, more and more of our patients are in Medicare insurance coverages. And so Medicare has deemed a schedule, a policy, a manual that helps determine what a patient's levels are. And we're going to talk about how to take folks through those different tests to, in fact, find out what their K level is going to be. So as we're going through these and I explain this, then you're going to understand if you're a patient, if you're a referral source, if you are another clinician, obviously you're well educated and well versed on what's going on here. So keep those aspects in mind as we talk about these documentation K levels.
Yeah, so it goes from level 0 to level 5. Is that correct?
That's correct. 0 to level 5, and K0 meaning you want to switch to the next slide here for us. So as we define those K levels, a very good topic here on this first page we have is, again, back in 1995, Medicare devised the system. You need documentation for your K levels, and you need to pass certain criteria to meet that documentation to have that type of prosthetic foot. So the K levels really refer to your two things: your prosthetic feet and your prosthetic knees, but mainly the prosthetic feet are what the K levels are helping to define, because that's your transportation on your prosthesis.
Right. Okay.
So as we're moving on to the next slide here, we're going to start with, again, the K levels are defined, but K0, our next slide here, Russ, as you can see. So K0 would be someone who is non-ambulatory, a patient that's in a nursing home, a patient that's in a skilled nursing facility, long-term care. Let's say it was someone who was paralyzed as a result of a car accident, or someone who has someone who's had a stroke, for instance. And as a result of having a stroke, they have paralysis on one side or the other. They were not ambulatory before they started, or before their amputation, I should say. And so as a result of having the amputation, that doesn't make them ambulatory, and we're not going to be able to provide a prosthesis to get them up and be ambulatory with the use of a prosthesis. So that's a K0 level patient, meaning they were not ambulatory before surgery. They're not certainly going to be ambulatory after surgery. They were wheelchair bound before, and it will remain that way throughout.
Okay, right? So the level 0 patient, just to make sure I'm understanding, will not qualify with any insurance, especially Medicare, to be able to receive a prosthesis.
That's correct. So okay. Our next slide actually shows that K level as a 0. If you can flip to that next slide here with our patient here in a wheelchair, this describes it specifically from Medicare guidelines. So this really helps to show you, and that's a great example of a patient who had a precondition before their amputation, someone who but still has diabetes, for instance, or peripheral vascular disease. They may develop a diabetic wound on their foot. You don't have to be weight bearing or ambulatory to have a wound pop up on the end of the foot or toe, or have peripheral vascular disease. Those issues happen for folks who are non-ambulatory as well. So with that said, sometimes they require amputations, but they weren't ambulating beforehand. So now as a K0, they're not going to be meeting the criteria to ambulate afterwards. So that's what a K0 level defines. So next slide we're going to talk about here is a K1. Okay. So a K1 level function would be a patient who is specifically going to be using their prosthesis for household ambulation. They have the ability to, or potential with a prosthesis to ambulate, do chair transfers on a very even terrain. So a prime example of this would be a patient who is homebound, someone whose goal is to strictly get up, make it to the toilet, make it to do hygiene, make it down to physical therapy, right? Someone who has assistance during ambulation. Typically those folks are going to be in the geriatric population, not necessarily. Remember, something I'd like to educate folks on, if you're not a clinician, is that we can't define your K level by your age. We define K levels by your activities. And so many times we think folks that are of geriatric age fall into an automatic K1 or a K2 population. Not necessarily true. That's why Medicare and other agencies have helped design tests that we can put these folks through, which we're going to talk about here at the very end. So again, K1 would be someone who is a household ambulator, limited in the
so they don't go outside.
Certainly unlimited in the house.
They don't go outside and go for walks.
They don't. That's correct. You're not going to see this patient out at Central Park Zoo ambulating with their prosthesis.
If they're outside, they're going to be in a wheelchair. Someone's going to be pushing them, or they're going to be pushing themselves.
That's correct. So what I find is that the K1 level patients really help with, again, transfers, simple household ambulation, and this really helps patients to understand, and clinicians as well, and referral sources to understand what this K level 1 means and how to define that.
Yeah.
All right. So now moving on to a K2 level. When I look at the spectrum of, again, geographically, it depends on where you are. So last week we talked about, or our last conversation, we talked about prosthetic feet and how those work and the function of those. So now as we're talking about how that correlates into K levels. So a K1 level patient would be that patient who may be going into a basic satch foot. So we talked about that single axis cushioning heel foot. That's exactly what we mean when we say a K1 level patient. As we move into the K2 level patient here, as you can see, and it's defined by Medicare and other guidelines, is that this is a patient who has the ability to ambulate over transverse planes or low-level environments. What do I mean by that? That's your patient who's able to walk outside, able to take a walk down a football, your basic track around your football field at your local high school. Someone who can ambulate in the community, right? They do their own grocery shopping. They have no problems getting up ambulating. And so that's the least of their concerns. But this is also a patient who has limitations. You're not going to find them out playing basketball. In other words, this would be a prime K2 level patient. And as we talked about last week, I brought a couple of different prosthetic feet here for you guys to see today. If you can switch back to me, Russ, we'll talk about that here in just a second. So as we're looking at these K levels on feet, I brought a couple of different prosthetic feet in today. These three prosthetic feet that you're looking at here all have hydraulic ankles. And so for us as clinicians, one of my favorite prosthetic components in feet are hydraulic ankles to put on my K2 level patients. Why? Because it allows an easy rollover through mid stance and during ambulation and weight bearing in your prosthesis. So as you can see, these 3 feet here that we have lined up, this is an Avalon foot that's made by Endolite Blatchford. This is an Odyssey K2 foot, and this is a Freedom K2 foot. And with that said, what these feet all offer is the ability to dorsiflex, like we talked about a few weeks ago, plantar flex. So with all that being said, on the prosthetic feet, again, we have the moving ankle, the ankle joint here, here, and here on these 3 prosthetic feet. So those are all good attributes to have. So again, this falls into a K2 level patient. So now we're going to move into the K3 level patient.
Okay.
So you can see I've got a couple of pictures here of patients who are standing around, right? These guys are all young and active, and you can tell they're highly motivated to ambulate and proceed with doing their activities of daily living with their prostheses. This is a functional level K3. So this is a patient who has the ability or potential for ambulation with a variable cadence. And the way I define a variable cadence to my patients is it's not necessarily someone who can speed up, but they also have the ability to slow down. It's folks who live on an uneven terrain, on farmland, on landscaping. I have a couple of patients who actually work for the city. And as a result, they're required to be up and down with different utility sectors in the area that require them to be on uneven terrain. Those are all K3 level patients. Again, the majority of these patients may be younger in age, but it doesn't necessarily limit you to being younger in age to be a K3 level patient. I have a 72-year-old who's a K3 level patient because she's very active in the community. As a matter of fact, she plays tennis, and she doesn't get out and run a 5K, but she is actively playing tennis, and as a result, she requires a K3 prosthetic foot. And so during our conversation a few weeks ago, we actually talked about having a K3 level prosthetic foot. And so that, if you remember specifically, that was the carbon graphite foot that I showed you. And I have a picture of it here, Russ, if you want to flip back to me again.
Yes, sir.
All right, so K3 level foot is what I have here. You can see this guy. This is called the Silhouette. It's through Freedom Innovations Prosthetic Components. And if you remember correctly, we talked about energy return and dynamic response. We also talked about inversion, eversion, and the multi-axial components that a prosthetic foot offers. Well, this is a prime example of a K3 level prosthetic foot. Someone who has the ability, remember we talked about during our definition of a K3 level patient, the ability to cross transverse planes, unlimited community ambulation, the ability to change speeds with a variable cadence. This is someone who's actively hiking. They're very active in the community, again, playing tennis, playing pickup basketball. A good friend of mine wears a prosthetic foot very similar to this, and he's a K3 level patient. He's 45 years old, has 2 young sons, uses this prosthetic foot for everyday activity, but he can also use this foot to play pickup basketball and water ski and do whatever he needs to do out in the community. So
You water ski?
This is your K3 level foot, and that's what allows you to do this. This is actually, I wouldn't say it's waterproof specifically, but you can get this prosthetic foot wet. All right. So your K3 level folks, remember, we've talked about K0 is a patient who does not have the ability for ambulation. They weren't ambulatory before their amputation.
You show that foot. Do you have one of those just basic feet there with you?
I don't have a basic Sachs foot here.
Okay, no problem.
But if you remember from our last conversation, it was the most basic foot that we've had around for 30, 45 years.
Yeah.
Again, that was your single axis cushioning heel foot. Not going to break any land speed records for it. It's not meant to be on uneven terrain. It's meant to strictly and specifically get someone up for first time ambulation. And again, those folks who have household ambulation priorities.
Gotcha. Now,
so to
K1,
cover where.
Then K1, what's that foot look like again?
So K1 falls into that area as well with the Sachs foot.
Oh, of course,
so,
yes. I'm sorry.
Medicare and other, Medicare definitions have designed and been very specific about a patient has to meet that really K2 level of criteria before you can actually widen the spectrum of different types of prosthetic feet that you're allowed to put on these patients. So once you get to a K2 level and you're able to test in that area as a patient, then we as clinicians and your physicians are writing progress notes and documentation that document, for example, Russ Sorrells is active in the community and feel like he would be a great K2 level potential patient. And potential is a big word that we use. It's a very important comment that we make in our documentation, because the potential, we can't determine definitively where you're going to be sometimes with your prosthesis, but we can determine that potentially you will reach those levels of ambulation and activity.
And the reason, I think you've explained this before, the reason for all of this documentation and confirming the K level is because there was a time when people were, clinicians and companies were putting Corvettes on people that were in wheelchairs. Is that one of the drivers for that?
That's sometimes one of the drivers, but more importantly, it just helped to define the boundaries, right, of what we could actually put on patients, because we certainly want to meet their needs. We want to meet patients' criteria and what their goals are. But this certainly with the K-level criteria helps. It's not perfect, right? We don't have a perfect system. Not every patient's going to fall into one of those. I have a number of patients who are in the K2, K3 level area, but as a result of their insurance, they may only pay for them to be in a K2 level foot. We have so many plans and different coverages today.
Right.
Our patients, as we always talk about, can be the biggest advocates of what they require and what they need for ambulation and their prosthesis. So it's key that that's why we do these Facebook Live conversations, is mainly to help educate patients on what they're wearing, why they're wearing it, what prosthetic needs they may have, and orthotic needs as we go forward. But this is important to remember for you as a patient. Educate yourself. And these are great topics that we have to educate yourself today. So we've talked about K0, which is non-ambulatory, not walking. K1, which is a patient who is strictly a household ambulator using their prosthesis to do transfers. And that's a big deal. That's a big priority. You can imagine if you're a caretaker out there for someone who's not wearing a prosthesis and you're required to lift them for chair transfers, how laborious that can be on your lower back and what it requires from you energy-wise. And then K2 level patients, as I talked about earlier, predominantly here in the Southeast, geographically, that's what I deal with specifically, is really K2, low K level, K3 level patients. And that's because of what our requirements are out in the everyday community, but mostly because, as we've talked about before, diabetes are a big driver in amputations here in the Southeast. As a result, sometimes those folks have secondary health issues. And so their activity levels may not go back to a K3 level as they were before their surgery, where they were unlimited community ambulators and variable cadence. So we mainly hang out in that K2 area, and we talk about, that's why that hydraulic ankle foot that we talked about allows them to have a smoother ambulation and walking speed. Just takes the abuse out of the residual limb and their prosthesis as well. So it's very good to have as we talk about K2 level. And then lastly, we just finished up talking about K3, right? So those are your athletes getting into that athletic background, folks who are just more active. I talked to you about a tennis player. I talked to you about basketball player, water skier, folks who are horseback riding, for example. And then we start to delve into younger amputees, pediatric cases, right? And so as we move into the K4 level, it's not difficult to define the K4 level, but you know it when you see it. And so a K4 level patient is someone you're looking at while running a 5K, someone who's doing a marathon. They're at a K4 level at that time that they're calling for those demands on their prosthesis. So this is someone who has unlimited activities in the community. They can do whatever they need. They can deer hunt, they can fish, they can farm, they can be on hilly terrain, they can be in landscaping. These folks are running around the football track. They're not walking, they're running, they're sprinting. These are the folks you see in the Olympics. But I like to educate patients on this fact, is that those folks are at a K4 level activity at that time that they're doing that activity specific sport. But during everyday life, during everyday activities, they hang out around the K3 level, meaning they're going to wear a normal prosthetic foot. If you'll flip back to me here, Russ, I'll show you guys a running foot that I actually have here in the office. Again, this is just a specific prosthetic foot that I keep here in the office as a trial. It's kind of cool looking, outer space looking. Technology is pretty cool. This is all carbon graphite, as you can see, and you can see the C shape of the prosthetic foot. You can see the flat foot plate here on the plantar surface of the prosthetic foot. This is actually a running prosthetic foot that has tread on the bottom, and it has a multi-axial component in the front, as you can see with the split keel here. So this foot's pretty cool because you can take this hiking. You could have this as an everyday prosthetic foot. I have a 14-year-old that I have this on, and going into that K4 level, most of our pediatric patients are in that K4 level because they're young, they're active, and they're very resilient. And so fitting a pediatric case, I don't want to say it's easier for us as clinicians, but it certainly makes things more simple for them to get up and ambulate, because we're not trying to change a 35 or 40-year-old's walking habits. We're changing a 2-year-old or a 5-year-old or an 8-year-old's walking habits. And as a result, they're super resilient. They adapt to their environments really easy. And so they are at that K4 level pretty quick, and they remain there. We've got a number of pediatric patients we take care of who are in a K4 level. And it makes my day as a clinician when I see my pediatric patients come in and they've broken their prosthesis, right? They broke their prosthetic foot. It's pretty cool, actually, because that means that they are able to get on and live life. And again, it's pretty neat with pediatric cases because they just kind of adapt and keep moving. And I have a few K4 level patients that have the activities to do this. If any of you are familiar with F3, we have a couple of adult men who are part of the F3 organization in the area, and one of them wears a below knee prosthesis and one wears an above knee prosthesis. and they both are actively involved in F3. And they both wear feet like this for their F3 activities. But in civilian life, or going back to work every day, they wear their K3 level foot. I will say that if you are a consumer of a prosthesis, a patient out there, a referral source, and you're looking at, well, the question I always get, Russ, is, am I allowed to have a running leg if I have a regular leg? And that's where we have to have a conversation of, typically insurance companies will pay for you to have one or the other. It's hard to rationalize paying for you to have two specialty prostheses, right? One for daily use and one for sports and activities. So sometimes when folks are venturing into getting a K3 level foot, what we find is that those are out-of-pocket expenses sometimes for patients, and they have to raise funds sometimes. We have scholarships available that they can apply for, and other funding agencies that really help subsidize that, as long as those patients are able to get back to their activities of daily living and meet the needs that they need with that prosthetic foot. So that's good information to know about the K levels. So again, K0, K1, K2, 3, and 4. And K4 is your highest level, K0 being your lowest level. And again, that document was initiated by Medicare back in the mid-90s to help us as clinicians and for our physicians and patients as well, to be educated on what they needed to do to meet the criteria to get those specific feet, right? So our next slide, we're going to talk about, so how do we determine who you are as a patient and what criteria you're able to meet to get there? And so specifically here at the Prosthetic and Orthotic Institute, we use specific tests. One is called the AMP Pro and one is called the AMP No Pro. What does that mean? It's the amputee mobility predictor. And when we say no pro, we mean without the prosthesis on. So we'll do an AMP No Pro with someone who's a new amputee. We'll take them through our test. There's a 21 question survey and questionnaire that we do, and we take patients through. It's a physical test that, for example, how many times does it take them to rise up out of the chair on their sound side? That determines the strength of the sound side limb that's still remaining. That's a big deal, because that tells us a lot about how your strength is getting in and out of a chair, right? We have a test that allows us to let you do a single leg stance on your unamputated side, your contralateral side, that allows us to use a stop clock to test you with that. And so we take you through those 21 questions, but then we also have the same test, except it's the amputee mobility predictor with your prosthesis. So that's the AMP Pro. And as we take patients through that really helps us as clinicians. I've highlighted here in red that test that we use a lot here at POI. And then going down further, we also have the Tug Test, and that's the timed up and go test. And I'd highly recommend, if you want to see these online, you could go to YouTube. You could just simply type in Tug Test or timed up and go test. Sometimes you'll see those without someone wearing a prosthesis. It may be a stroke patient. It may be a patient with MS, but the tests are all the same. It's a timed up and go test. We test how fast and how long it takes you to get up out of your chair, walk around the corner, walk down the hallway, come back, sit back down in your chair. Why do we test that? Because that's a big majority of what we do throughout the day. We walk, we sit, and we get out of chairs. Mm-hmm. And if you can reach those daily criteria, then we know we're going to have a positive outcome. And so those are a couple of the tests we do. We do a cadence walk test where we actually will time your cadence back and forth, a 10 millimeter walk test. We also do. Those allow us to see a 10 meter walk test, allow us to see just how fast your ambulation is for 10 meters. Those tests, again, are all online on YouTube. That's a great resource for us to use here at POI. We typically have those documents in the chart. So when a patient is fit with their final delivery of their prosthesis, right, we'll take them through an AMP Pro, which is the amputee mobility predictor with their prosthesis. Why is this important? A couple of reasons. Number one, we are in a culture and society and a reimbursement era of where folks want to see results. We want to see and test, how are you doing today versus where are you 6 months from now? And again, I go back to my teenage daughter. You're driving at 16. You got to completely stop at the stop sign. We got to make sure that you turn your turn signals on. It's a test, right? And then 6 months from now, Dad gains a little more confidence and he rides in the passenger seat with you. And he has a little more patience because he now knows you have confidence to be driving, much like in a prosthesis. If we fit you on with that on June 1st, we take you through the AmPro. Well, what does it look like in December? We're able to document that on a follow-up visit. And those criteria and those bases are very important to have a documentation for Medicare to come back and look in your charts, to look at the patient results, and to just deem that prosthesis is medically necessary for that patient and it's helping them to reach their outcomes. Because we also have patients who actually digress from being a K3 to a K2 level patient. So who would that be? That would be a patient who maybe at age 45, they had an amputation and they were a K3 level patient up until they were 72 because they had some secondary health issues. And now they've digressed back to being a K2 level patient. Well, we've got to meet their needs with that K2 level prosthesis, right? We're giving them more safety, comfort, and confidence by putting them into a prosthetic foot that meets their needs at that time. So these tests are important. They measure as we talk about, anything that's worth doing is worth measuring and worth testing for an outcome. And so that's why we use these tests, and that's why they're so important.
Excellent. So a couple of questions I want to ask. So if I'm a patient, what specifically do I need to know? And you've covered a lot and you've talked a lot about this, but is there any one point that you want them to take away as it relates to K levels?
Actually, yes. There's a couple of high points, but one specifically I think of is that so oftentimes we as clinicians need for our patients to be advocates for themselves,
right?
And understand, again, why are we putting you in a K2 level prosthesis? Why are we putting you in a K3 level prosthesis or a K4? It's always wise for the patients to understand and be educated on why they're getting these and how it works and functions. So that is a highlight right there, is for patients to be educated on their prosthesis and their K level.
Okay. So what about our physical therapist and referring physicians and our other referral sources? What do you want them to know about K levels?
Good question. Your physical therapists are vitally important in helping determine what your K levels are. So we as prosthetists are good clinically, right, at the biomechanics and building your prosthesis and gait assessment. Here's the thing. When I just fit a patient yesterday with their initial prosthesis and they're starting physical therapy next week. It is vitally important for the physical therapist to understand what K levels are and to take them through an AmPro in their office or their facility. And we have local facilities in the Charlotte area and Rock Hill and Lancaster area that are very keen and educated on this. There's very sharp, intellectually sound physical therapists who take these patients through these criteria. I think of several physical therapists in the area who really get the best results by testing initially when your patient enters the clinic, if you're an outpatient and even inpatient. You test them the first day they arrive, and then you test them 3 weeks later, and it's pretty neat to see the results. So if you're out there as a patient, as a physical therapist, it is vitally important that you as a patient and your physical therapist understand the AMP No Pro, the AMP Pro, the Tug Test, and they're all familiar with these tests. Specifically the Tug Test, I know, but with the Amputee Mobility Predictor Test, some therapists are very educated on these and some just have not been educated or taken any classes on this, and I would highly recommend reaching out, finding more information about that if you haven't. I teach locally here at a two universities where physical therapy departments are educated on K levels and gait performance in a prosthesis. And so we make it a point to do that whenever we're teaching those classes. And then for our physicians, so many times for us as clinicians, we need to get components for our patients and what they need. And it is important, even going forward more and more, that the criteria that I document as a prosthetist, that the physical therapist documents, and that the physician documents all coincide with each other. And in other words, we're all in agreement of a plan for that patient. Mm-hmm. And so it's important for your physician, specifically for your physical medicine and rehab physicians, right? So your physical medicine and rehab physicians are really the key in the cog here, because they are what determine, and they are the ones who are writing these prescriptions for your prosthesis mainly. Because so many times, as I had the conversation yesterday, once your surgeon has performed the amputation and he has cleared you for weight bearing, well, then you're kind of out of his hands. And so it's important for you as a patient to become familiar with physiatry care and physical medicine and rehab. They are your confidants in knowing and educated information and treating the entire body, but also treating your system, your prosthetic needs, your amputation needs, your phantom pains, for example, the neuropathic pains that come after amputation. Your physical medicine and rehab doctors are all educated and experts in this field. So that, as it coincides with K levels, is important to remember as well. So really, those three team members, along with occupational therapy as well, especially if you're an upper extremity amputee. The K level doesn't necessarily correlate to upper extremity amputations, but occupational therapy plays a huge part in the donning and doffing of your prosthesis properly. And so when you're having home health, inpatient rehab, your OT, your PT, your physiatry with physical medicine rehab, and your prosthetists are all part of the team. So those four cogs are what all help this system go, right? And so all of our documentation has to correlate to each other, agree with each other, and that really helps to summarize and explain a story to your payer. So you're really, as a patient, you're explaining to Medicare or your insurance payer what your story is and why they should be helping you to get your prosthesis.
Excellent. Well, that is great information. That I'm much more educated than I was before on K level, so appreciate that. Any follow-up, any final thoughts on K levels?
I think we covered pretty much it. I think I'd like to iterate, if someone has questions, concerns, they can reach out to us. You know where we are. We're doing these weekly, and hopefully these are educational. We'd certainly like some feedback about whether they've been helpful or not for patients. I know we've received great feedback, great views and reviews on these, and so we'll keep bringing them and giving you guys value and helping educate our patients and our referral sources.
Absolutely. That's so important that that we continue that effort, right, with our patients and providing this information. That's what we want to do. We know that educating patients and referral sources is a key component to growing this community. A knowledgeable patient and an advocate for themselves, that's what we're looking for. So anything we can provide, any other subjects or topics that patients would like to know more about, please don't hesitate to ask us. Just comment, send us an email. It's my email is russ@poibelieve.com, kelvin@poibelieve.com. We're open to any suggestions. So we just appreciate all of our patients, all of our referral sources, and the opportunity to serve you each and every day.
Absolutely. Thank you guys for joining us.
All right. Take care. See you, everybody. See you, Kelvin.
See you, bud.